When we are doing biopsies anywhere in the gut, we are generally targeting areas that look visually abnormal on the one hand, but if the lining of the esophagus or stomach or small intestine or colon looks normal, we take a number of random biopsies in order to try to sample effectively enough that the biopsies are then representative of the tissue, even if the disease is somewhat patchy.
When patients undergo endoscopy for the assessment of their intestinal tract, there are two factors that are considered. One is if there's an abnormal area that's identified, we'll get a biopsy of that area because that's the most likely place that we might see inflammation or disease activity. The other is that as a part of all of our practices, we perform endoscopies in a standardized fashion to get biopsies of the top and the middle and the lower part of the esophagus in certain numbers to identify whether or not disease activity may be occurring.
With biopsies, sometimes it's like the Sutton's law. I don't know if you have heard of it, where he was a bank robber and people would ask him why does he rob banks. He would say that's where the money is. So with this, sometimes with biopsies what we do is obviously if it looks abnormal, red or nodular or thickened, we'll biopsy, which is usually with eosinophilic gastritis, which is the stomach or the small bowel or the colitis, because you see red patches. With eosinophilic esophagitis, generally the inflammation is more intense, more diffuse, more involved. And in that instance, what the mainstay is to make sure you biopsy enough biopsies from different areas of the food pipe. So you biopsy from the lower food pipe and the upper food pipe are the areas we would biopsy. You cannot just go with one level biopsy in eosinophilic esophagitis, you have to go at multiple level biopsies.